Good morning, everyone. I'm very glad to be here again. Today, I would like to present how to approach ARDS. ARDS is a pulmonary edema induced by increased permeability of capillary endothelial cell and alveolar epithelial cells. And as we know, ARDS mortality is still high. In severe ARDS, the mortality reported as 45% in average, even in high-income country. So we may ask what we had achieved since its first report in 1967. In the first report, already the efficacy PEEP, positive and expiratory pressure, was revealed most helpful in combating atelectasis and hypoxemia. So since then, how we evolved our management in ARDS, we slowly recognized that the ventilator-associated lung injury, especially the high tidal volume, leading to a landmark clinical study in 2000, low tidal volume strategy in ARSNet group. Based on the pathophysiology of the ARDS, up to now, there is no effective specific treatment, as you know. So still we are quite keen to treat underlying diseases to develop ARDS and also the ventilatory support to meet the patient oxygenation state. Clinicians start to think how to prevent ARDS development at risk group and how to carefully maintain patient status until the recovery of the damaged lung. And together with that, how to accurately diagnose ARDS, which is a syndrome. So the new definitions issued 2012, as we have a syndrome definition, new definition also needs clinical interpretation regarding chest X-ray and the origin of pulmonary edema. So therefore, correct diagnosis is not easy, as shown in this investigation. Inter-observer reliability on ARDS diagnosis using Berlin definition was only 0.61 within 12 hours of invasive ventilation, and even not much improved during the first day of admissions. Practically, difficult to apply at patient bedside. However, two groups of 3 observers make an agreement. The agreement ratio is improved up to 0.7. So we think about whether it could be preventable then. As you know, the earlier diagnosis is not easy, so the prevention also is not easy. However, according to this population-based study result, almost 67% of the ARDS developed after admission to the hospital, and went to this up to 72 hours, almost 60% patient require the time until to develop ARDS. So we would say we have some window period to prevent at the risk group. This table, figures, shows the predisposing condition of the ARDS. So if we prevent the second hit, such as aspiration or infection progressions or proper management of shock, we may reduce the development of ARDS at the risk groups. And another approach we hear in these sessions later. If we pursue less invasive way to manage hypoxemia using high flow nasal cannula or non-invasive positive pressure ventilation, although a big debate, its efficacy in severe hypoxic lung. We may reduce any ventilator-related further lung injury. One cautious thing, it is our data. Whenever we pursue less invasive way to meet the hypoxemia, one big issue is how we appropriate make a time for the intubation. So if we fail appropriate timing intubation, as shown in our data, the ICU mortality is significantly increased. Even intubated already with the hypoxemia, if we give the low tidal ventilation, 6 ml compared to 10 ml per body weight kilogram, the odds of risk ARDS development is significantly decreased. We need a plan because the ARDS patient is high mortality to avoid any unnecessary suffering in the patient who could not be survived. So we need a plan how far our management be provided depending to the patient condition at earlier stage of the ARDS through the family discussions. For the plan, whether we should manage the ARDS patient, the level, to determine the level, we need a very good prognostic index. According to this scoring system using the AZ, PF ratio, plateau pressure at 24 hours after ARDS diagnosis, if the patient is scoring higher than 7, the mortality is reported of 83%. So if we have a good prognostic score like this, if appropriately function, then we may begin the patient, family or patient, whether how far we should go. On contrarily, if the patient may have a higher chance of recovery, we can manage it the more intensively, as like this patient. 30-year-old lady, the first pregnancy with a 30-week gestation with viral pneumonia and severe ARDS development, and then we consider ECMO and then let her survive. Lastly, we should be more prudent when we manage the ARDS patient. The prudence include avoid the potential harmful treatment, more cautious ventilator management, and conservative fluid therapy, less sedation, and to prevent nosocomial infection, focusing on hand washing enhancement and appropriate antibiotic use. One of a classic example of the medication to be careful is steroid. Steroid is recommended since its first publication. As shown in this data from Japan, based on the nationwide the administrative database, in these groups, the patient who received the steroid, although they use rather high dose, showed a more detrimental patient outcome. To attenuate ventilator-induced lung injury, we should know the key derangement of lung mechanics. Lung mechanics, as you know, in ARDS decrease the functional residual capacity and frequently associated with increased chest wall elastance, leading to decreased respiratory system compliance. So what we have to more protective mechanical ventilation, we combine the tidal volume and PEEP, observing the plateau pressure to lessen stress and strain of the alveoli and to attenuate ventilator-associated lung injury. We acknowledge transpulmonary pressure gradient is a matter in ventilator-associated lung injury. In non-homogeneous lung like the ARDS, the local distending pressure is highly augmented by usual tidal volume. One of physiologists estimated effective wall stress through a mathematical model. Dr. Mead suggests the effective wall stress is applied pressure product alveolar volume change to 2/3. So if peak inspiratory pressure is 30 centimeters of water, if the alveolar volume change is 10, according to this equation, effective wall stress will be 140 centimeters of water. So it could not be imaginable when we do the daily mechanical band. So could it happen to 10 times alveolar volume change? It is a surfactant depleted animal model. Gary Neiman in New York observed through the videoscope, and he observed one of the alveoli type changes volume 10 times. So it could be happen in our ARDS patient group. So it has been proven through the landmark study, low tidal alveolar distension strategy. Another still remained issue is how to set the mechanical PEEP level together with the low tidal ventilation. PEEP setting should be different depending on the lung compliance and the chest wall elastance. So in the patient with a steep chest wall, if you give the higher PEEP, the transpulmonary alveolar pressure gradient is not much increased compared to the soft chest wall elastance. The patient group with the pulmonary ARDS, reported in 1998, Dr. Gattinoni observed that when we apply the PEEP pressure up to 15 centimeters of water, in patient groups, the pulmonary ARDS who usually do not have much increased chest wall elastance, does not improve any respiratory system compliance. However, in patient group, in extrapulmonary ARDS, such as trauma, frequently, combined with the higher chest wall elastance, by applying up to a PEEP level up to 15 centimeters of water, improve the respiratory system compliance. So we can get some tip when we set level of a PEEP depending to the patient status. Another way, has been prevailed in our patient bed settings. Our group is one of the groups to develop alveolar recruitment maneuver. The decremental PEEP trial, after we recruit alveoli through the very transient time of high PEEP. However, the efficacy proven it rather detrimental by applying decremental PEEP trial after alveolar recruitment maneuver. Since this publication by Dr. Amato, driving pressure, which was revealed as only surrogate prognostic markers of the ARDS patient outcome, clinicians much increased the interest how the driving pressure be adopted in our daily practice. As you know, driving pressure is defined as a PEEP, plateau pressure minus PEEP, is interact with the chest patient respiratory system compliance and also the associated with the tidal volume and PEEP level. And we still don't know whether driving pressure is a target value to set or is a surrogate marker of the patient prognosis. As another adjunctive way is prone ventilation. Prone ventilation induces more uniform ventilation, attenuating the effect of gravity. So as shown in this animal experiment, compared to the supine, prompt ventilation shows better uniform ventilation. And it is our animal experiment data. Even in two different levels of PEEP, prompt ventilation compared to the supine ventilation recruited the lung more together with the better oxygenation. So we would say prompt ventilation has PEEP sharing effect. So it led to the multi-center clinical trial. Through the multi-center clinical trial, proved its efficacy in severe ARDS. Neuromuscular blockade used within 48 hours severe ARDS also reported to improve the patient outcome. So practically, if plateau pressure is higher than 28 centimeters of water under use neuromuscular blockade, and if patients do not show the adequate oxygenation, so how will you do? If saturation is above the 88% with the FiO2 less than 0.6, we may wait until patient damaged lung recover as far as patient PaCO2 tolerable. However, if the saturation is less than 80% and required FiO2 is higher than 0.6, then we may consider extracorporeal CO2 removal in patients with a higher chance of recovery. And we can reduce more tidal volume to reduce more plateau pressure. As shown in this patient, we reduced the patient tidal volume the 120 and let the patient the plateau pressure less than 25, and then wait until patient recover. Fluid management, the highly stressed because the in ARDS is a permeable type edema. Inappropriate fluid administration, aggravate the pulmonary edema, also lead to surfactant dysfunction together by the alveolar flooding. So in the factor trial showed that after patient hemodynamically stable, conservative fluid management led to increase the number of ventilator-free days and decrease lung injury score. However, follow-up data of the survived subject showed that the conservative fluid management strategy was associated with cognitive impairment of the survived. So still, it is very quite difficult how we approach the fluid management in patients with the ARDS, with the shock. Less sedation is much stressed in these days. And also early rehab is quite needed. However, it is require many people be, needed for the appropriate early rehab with under mechanical band. What is the future directive? We wait a strategy to recover lung fibrosis induced by ARDS. There is no good strategy to recover the lung fibrosis in this, as shown in this chest X-ray. We also tried the stem cells, but could not have any positive result in our clinical experience. Another future we waiting is recently ARDS has some subphenotype, hyperinflammatory and hypoinflammatory, and they reported that simvastatin, which has reported no beneficial effect in ARDS outcome. However, they found that through the subgroup analysis, higher survival rate in hyperinflammatory subtype of the ARDS. So we wait more practical, the index to discriminate the subphenotype of the ARDS to apply more the reasonable approach of any anti-inflammatory trial. So let me make a summary. What we should not miss. Firstly, accurate diagnosis. So even experienced physician, whenever we see the patient chest X-ray with the bilateral infiltrate, it is truly a permeability type edema, or whether it is more bilateral severe pneumonia. So it is quite intriguing. So accurate diagnosis is one big issue still, and the prevention, whenever we handling the patient group at risk, we may be more cautious and more keen to low tidal ventilation and to fluid management. And also the ventilator setting, whenever we are doing the synchrony and heart-lung interactions and the rest injurious way and achieving optimal oxygen delivery. And also the protocolized sedation and early rehab we should do. In reality, it was done by the UK, it was done in North America, in Chicago region, and they found that less than 20% of the patients treated the low tidal volume ventilation. So Asian intensivists may not be different. That's the reason why we are doing the improved study in this year. 15 Asian countries will join for how the ventilator setting in our Asian intensive care unit. So it is the ventilator in our medical ICU put on the tidal volume per 6 to 8 ml per kilogram of the ideal body weight. So whenever we do patient round, we look at whether the tidal volume is appropriately setting. So it is my last slide. When we set mechanical vent in the patient with the ARDS or ARDS at risk group, 6 ml tidal volume, looking at plateau pressure, and the PEEP setting according to patient, the chest wall elastance. If the oxygenation is optimal, we may continue until patient damaged lung recover. If not, we may see the driving pressure and the level of FiO2, also PaCO2, and consider whether we do the esophageal pressure guided PEEP setting. It is not easy though, or NM blockade use from ventilation, or extracorporeal CO2 removal. Thank you for your attention.